My name is Spiro Cataland. I'm a hematologist at The Ohio State University, and I really want to thank the organizers for allowing me to record this presentation for this session on autoimmune hemolytic anemias. TTP is sometimes not thought of as a hemolytic anemia, but as you'll see, the hemolysis, the mechanical hemolysis, because of the widespread small vessel microthrombotic disease, is really one of the hallmarks of the disease that helps you to diagnose it. So to start out, whether we're talking about immune-mediated, the acquired form of TTP, or the congenital form of TTP, the signs and symptoms with acute episodes are quite similar. You may see fatigue, nausea, abdominal pain, and neurological deficits, which could be very minor, confusion, to more significant motor deficits, cognitive deficits, and overt coma and stupor as well. Because of the thrombocytopenia, you can see bruising, and petechiae, signs of a low platelet count, but certainly the primary issue in TTP is the widespread microthrombotic disease that really leads to these symptoms and their presentation. I really like this illustration from the late Evan Sadler. Really shows, I think, quite well the pathophysiology of TTP. Again, whether it's the acquired form or the congenital form of TTP. And in the normal state, what you see is the production of these ultra-large multimers of EWF secreted from endothelial cells. And under conditions of higher shear forces, they get stretched out and then cleaved by this ADAM TS13 protease. This protease cleaves these ultra-large multimers down to the physiologic size multimers that mediate clotting and thrombosis where you need it to occur, not where you don't want it to occur. Down below in the pathological state, whether you lack the protease completely from birth, as in congenital TTP, or you acquire an antibody that either clears or blocks the function of it, what you get is the failure to cleave the ultra-large multimers, and then they can spontaneously bind platelets and form microthrombotic disease in the smallest arterioles. This happens under higher shear forces, which you see in the arterioles, and that's why you see the microvascular disease. When you get these microvascular clumps of platelets and von Willebrand factor, red cells that go whizzing by will get torn and mechanically hemolyzed, and that's the hemolysis that you see in TTP. So the hemolysis is a sign of the disease. It's a result of the microthrombotic disease, which really drives the clinical presentation of TTP. It's interesting to look at some of the evolution of the symptoms over time. If you look back initially when the disease was just described, no known therapy, and really what you see is observational studies that describe the course of the disease, what you saw was a near uniform mortality rate, but nearly all of these symptoms that were described previously as the pentad of TTP were seen. Thrombocytopenia, this hemolytic anemia, not autoimmune but mechanical, neurologic symptoms, kidney disease, as well as fever. But as you start to move forward in time, you start to now in the 80s get the hint of a successful therapy with half of patients surviving, and then beyond 82, where you see nearly all patients. And today that mortality rate is down to about 5%. But with this improvement in survival, what you see is the need to start therapy as soon as possible to allow for the improvement and block this mortality. So what you see is not waiting for all these symptoms to be fulfilled, but the more common findings that happen initially, which is a low platelet count and this microangiopathic hemolytic anemia, these fragmented cells or schistocytes you see in the peripheral blood. So with the improvement in therapy, you have the improved need to recognize this disease more quickly and start treatment as soon as possible. So Dr. George told me he initially spent half his career teaching the pentad of TTP and has spent the second half of his career telling people to forget the pentad of TTP. It's just the thrombocytopenia and the fragmented cells that you need. So how do we treat the immune-mediated TTP or the acquired form of it? It's plasma exchange therapy, which removes the plasma from a patient's blood and replaces it with donor plasma. So what you're removing is antibodies, and what you're adding back is functional ADAM TS13 protease. Now this takes several days to exert a clinical effect the removal of the antibody is not immediate and not total with one procedure, so multiple procedures are required. What's also required is immune suppressive therapy to really block the cause of the disease. So it's the production of these antibodies that either clear or block the function of the ADAM-TS13 protease. So steroids, rituximab, as well as many other immune suppressive therapies are used to decrease the production of the antibodies while you're removing it and adding back functional ADAM-TS13 protease as well. We'll talk about this more in a little bit, but one of the newer developments in the only FDA-approved treatment for immune-mediated TTP is caplacizumab. So caplacizumab is a small molecule, a nanobody, which binds to the A1 domain of amyloid factor. So by binding to this is the A1 domain where it tries to bind platelets and form the microthrombotic disease. So caplacizumab does not change underlying disease. It just blocks the ability of the patient to form the microthrombotic disease that they're trying to do because of these ultra-large multimers. So this has been effectively incorporated into the treatment of TTP. While you're doing plasma exchange and immune suppressive therapy, you're blocking the downstream effects of the disease with caplacizumab. So an important medical advance, and we'll talk about that more in some upcoming slides. But also it has to be remembered that this is a temporizing measure that does not change the biology of the disease. If this is congenital TTP, you don't have an antibody, you don't need immune suppressive therapy, you just need to replace the protease. So patients, after diagnosed, will just get plasma infusions. It should be emphasized up front at initial presentation. You can't really reliably tell the difference clinically between an acquired or congenital form of the disease. So at diagnosis, a congenital patient might get plasma exchange therapy as well, until you start to notice there's no inhibitor, but also you may notice a more rapid recovery in patients with congenital TTP who get plasma exchange therapy. So go into some more detail about the immune suppressive therapy that we use as well as the caplacizumab. We've talked about steroids are given with rituximab as adjuncts to plasma exchange therapy. And the steroids, like the rituximab, slightly different mechanism of action, but they have the same goal, to decrease the production of these anti-ADAM-TS13 antibodies and allow for the recovery of native protease function. Rituximab does this by targeting as an antibody, a monoclonal antibody, against the CD20 positive B cells. So these are the cells making antibodies. So again, a more targeted approach than prednisone, but same goal in mind, decrease the production of these anti-ADAM-TS13 antibodies. But it's going to be important as we talk about exacerbations, an important endpoint in TTP clinical treatment is the time for responses to occur. And what you can see here measured in blue is a prednisone arm of a randomized study that we did at our institution. This is the cyclosporin treated patients, less important for what we're talking about here. But what you can see is in patients receiving steroids and plasma exchange, you see the antibody levels as well as the ADAM-TS13 activity. And this is the median ADAM-TS13 activity, pre-treatment and week 1, 2, 3, and 4 after discharge from the hospital. So this is week 1 and 2 is actually going to be week almost 3 and 4 from the initial therapy. And what I think it's important to appreciate is that the median ADAM-TS13 activity doesn't start to clearly get above 20% until several weeks after discharge from the hospital. So there's a time effect required to suppress these antibodies. And as you'll see, this time-dependent response is not quick enough typically to help prevent exacerbations of TTP. This is with steroids and plasma exchange. If you look at some data from Marie Scully in the London group, you can see rituximab treated patients who also got rituximab and corticosteroids. I'm sorry, got rituximab in the first 3 days. And you can see the ADAM-TS13 activity and the anti-ADAM-TS13 antibodies starting for remission and then day 8, 15, and 22. And what you see is the same effect. We think 20% or above is the level that's required to prevent an exacerbation or recurrence of TTP. And that takes several weeks to occur. So as we're going to talk about in the next slide, I believe the window for exacerbations is greatest in the first 2 weeks after discharge from the hospital. really before rituximab had the ability to help the majority of patients. So it's important to talk about standardizing terminology both for clinical care but also for research. And this was done a couple of years ago with a consensus paper from the TTP International Working Group. And we standardized the definitions to, as you see here, a clinical response is normalizing the platelet count after getting plasma exchange. A clinical remission is a clinical response that lasts for 30 days after stopping plasma exchange. But an exacerbation is the recurrence of a thrombocytopenia, or the recurrence of TTP, if you will, in the first 30 days after stopping plasma exchange or any additional anti-VWF treatment. Relapse is a recurrence that occurs beyond 30 days of plasma exchange or anti-VWF treatments such as caplacizumab. What these are supposed to do is differentiate what is a continuation of the previous episode for exacerbation versus a relapse, which is a new distinct relapse of TTP. But it's important to emphasize that exacerbations of TTP are a significant clinical event. As you said already, it's defined as recurrent thrombocytopenia, the need to restart plasma exchange therapy within 30 days of the last plasma exchange or anti-VWF therapy. So it essentially measures that could prevent or block the recurrence of the disease. This is a recurrence in the first month after it's stopped. It tends to occur in the first 2 weeks. It will occur in a third of patients, and it is a significant clinical event. Patients are required to go back to the hospital typically. A central line has to be replaced, and they're essentially starting over with another course of plasma exchange therapy. So this is a significant clinical event that, as you can see from the previous data, that rituximab and steroids really have not been able to address. This is the schema from the phase 3 caplacizumab study, Hercules study, which was the licensing study which led to the FDA approval and EMA approval of caplacizumab for the treatment of TTP with plasma exchange. And what you can see from the design of the study, plasma exchange was given either with placebo or caplacizumab. The drug was continued after a clinical response was achieved. So in those 30 days, that window where we judge exacerbations, caplacizumab or placebo was continued. And again, because of what was learned in the prior study, if the atom TS13 activity had not recovered to at least 20%, an extension was allowed for caplacizumab or placebo, if you will, for intensifying immune suppressive therapy. So this was the schema. It's important to understand that caplacizumab was given to cover this exacerbation time period to really assess its ability to block these exacerbations. And what I think sometimes doesn't get emphasized enough is really the most important aspect of caplacizumab is the ability to block these early recurrences or exacerbations of TTP. And what you see here is clearly nearly 40% of patients who got placebo suffered an exacerbation compared to 4% on the caplacizumab arm. So clearly having an effect on blocking these early recurrences of the disease until you can improve the atom TS13 activity, which just may take additional time. It's important to talk about safety as well, and anything that blocks your normal VWF function, blocks microthrombotic disease, is also going to have an impact on bleeding. And what you can see is exactly what you might expect is mucosal type bleeding, epistaxis, gingival bleeding, bruising, and hematuria, all of which were more common in the caplacizumab treated patients. So what you're doing is trading, if you will, a mild bleeding disorder from a more severe thrombotic disorder. But caution has to be exercised in patients with active bleeding, which is not common in TTP. But if there is active bleeding, you've got to be careful with the use of caplacizumab because it can exacerbate those issues. So what about caplacizumab without plasma exchange therapy? Can you treat this alone? And the very first patient to do this was a Jehovah's Witness who does not wish to, based on religious beliefs, receive blood products. And there was a patient in Louisiana successfully treated with caplacizumab without plasma-based therapy, which really started to raise the question, is plasma exchange or caplacizumab just a temporizing therapy? Can they be replaced for each other? Are they equivalent? Essentially, is there a biologic effect of the plasma exchange, or are they just both temporizing? As you can see coming up, the treatment is really moving toward the use of caplacizumab without plasma exchange. And this is a patient that we take care of that now a couple years ago came to the clinic, had some abdominal pain, a bit of nausea, and she was concerned because of her previous history of relapses of TTP, and she was worried about what this meant. And sure enough, just as she was concerned about, she was thrombocytopenic with a platelet count around 70 or 80,000. Her LDH was increased, and as we eventually found out, she had undetectable ADAM TS13 activity, and clearly this was an early recurrence of her TTP. But she was adamant. She said, I don't want to come in the hospital for plasma exchange therapy. I don't want to do it. Do we have any other options? And then we discussed the use of caplacizumab since she was early on in what would appear to be a recurrence of her TTP. So based upon our discussions and our ability to rapidly get caplacizumab, we were able to give her caplacizumab as an outpatient actually, and over the next 2 to 3 days, you start to see the improvement in the platelet count and a decrease in the LDH. So again, these are consumptive, meaning the platelet count goes down, the LDH goes up because of the microthrombotic disease. You're blocking that formation and you get the recovery of the patient. Now, she eventually received rituximab, and you can see the 4 weekly doses, and over time improved the ADAM TS13 activity to the point where she was able to stop caplacizumab. So clearly a case of a successful treatment of a patient with caplacizumab without the need for plasma exchange therapy. So this experience grew. There's an even more significant experience from the German and Austrian groups treating patients with caplacizumab without plasma exchange therapy, leading to what's known as the MAIARI study, which has just concluded enrollment several months ago. So patients with a clinical diagnosis of TTP were enrolled. They received immune suppressive therapy with prednisone and rituximab anti-CD20 therapy. And the primary endpoint was the proportion of patients that were able to achieve a remission of plasma exchange, remission of TTP without the need for plasma exchange. So patients were started on caplacizumab, and laboratory studies were obtained every 4 to 6 hours, and then at regular time points after that. It was up to the discretion of the physician whether or not plasma exchange would be started, but parameters were given. And within the first 24 hours, if you didn't see a rise in the platelet count or a decrease or absence of rise in the LDH in the first 24 hours, patients would be started on plasma exchange. After 5 days, if the thrombocytopenia was persistent and the elevated LDH persisted, patients should be started on plasma exchange, as well as progressive ischemic organ injury, neurologic, cardiac manifestations, or worsening renal function. And the study had just completed enrollment, as I stated earlier, and we're anxiously awaiting the results to determine and to see if any patients required plasma exchange therapy or could they be treated safely with just the caplacizumab alone. So the other development that parallels the development of caplacizumab is the development of recombinant ADAM TS13 to treat both congenital, especially, but also immune-mediated TTP. And what you can see in this left panel were congenital TTP patients. So again, these are patients who don't have an antibody, they just lack the protease. They received 1 dose, and the time course of the ADAM TS13 activity was followed over time. Clearly showing the safety. I didn't show you the safety, but it was safe, it was well tolerated, but showing the biologic effect in the improvement of the ADAM TS13 activity, but also metabolism of these ultra-large multiples was shown. But roughly at the same time, you saw some in vitro studies looking at patients' plasma with increasing quantities of inhibitors, so the strength of the anti-ADAM TS13 antibodies. And what was shown in the lab, at least, is that with increasing doses of the recombinant ADAM TS13, you were able to overcome the presence of increasingly stronger inhibitors, raising the question that could this drug be effective or useful in immune-mediated TTP, the acquired form of the disease. And there was a phase 2 study of using recombinant ADAM TS13 with plasma exchange therapy. The study was quite small. The arms are a little bit heterogeneous, but on the 3 arms of the study, 10 patients received placebo, so just plasma exchange immune suppressive therapy. Arm 2 received recombinant once a day, a dose of 40 units per kilogram, and a twice daily dose of recombinant ADAM TS13 with the plasma exchange therapy and immune suppressive therapy. So the most notable thing seen in this study really was in the ADAM-TS13 activity after the initiation of therapy and what occurred over time. And after 3 plasma exchange procedures, the majority of patients, nearly 80%, will still have less than 10% ADAM-TS13 activity. But you can see in this graph, and the brown bars represent each day's plasma exchange procedure. And you can see the ADAM-TS13 activity over time in the arm 2 once daily in light blue. The darker blue is the twice daily, and the change over time. You can see a slow but steady increase over time. And remarkably, after only 3 plasma exchange procedures, in both the twice daily and once daily, you have a correction to above normal or 100% ADAM-TS13 activity. It's important to note you're measuring this immediately prior to the next plasma exchange procedure and not immediately after, where you'll see increases just from the infused plasma as well as recombinant ADAM-TS13. So this is the first sign that you're actually changing the biology of the disease with the recombinant ADAM-TS13, whether it's just the replacement of the protease, is it the chelation of circulating antibodies? That's not absolutely clear. But these data are obviously encouraging enough to lead to a recombinant ADAM-TS13 with minimal to no plasma exchange study. So essentially mirroring what was done in the caplacizumab without the plasma exchange study. And the short form of the study synopsis, these are acute immune TTP patients. They were randomized to twice daily 40 or 80 units per kilogram. They received immune suppressive therapy, or they are receiving immune suppressive therapy. And the objectives are looking at the safety, but also the proportion of patients who can safely achieve a clinical response, a responsive TTP, without the need for plasma exchange therapy. And this study is now ongoing in accruing patients and doing quite well. So the future is certainly bright for patients with both immune and congenital TTP, and we have much to look forward to and improve the outcomes of our patients. And with that, I'll stop. I'll thank you for your attention and show you a slide of my most recent happy place I just found in North Berwick, Scotland. A nice, beautiful golf course called the Western Lakes. Thank you very much for your attention. Enjoy the rest of the meeting.